Traumatic shoulder instability in adolescents. Adolescent shoulder instability presents a challenging problem, and for those physicians with a sports-focused practice, there are new evolving additional challenges. This is partly due to an increase in highly competitive contact sports at a younger age, structured strength and conditioning, so adolescents are a lot bulkier, and also due to the increased expectations. These are career aspirations with the patient, parents and sometimes teams, and also expectations of treatment success. Avelius, from a study in the late 70s, identified that patients under the age of 22 who sustained a first-time traumatic anterior dislocation had a 72% chance of redislocating, and that 40% of the total number ended up having surgery. A more recent study of patients exclusively under the age of 18 looked at 133 patients with an average follow-up of 95 months. They found that 102 of the patients, so 78%, had redislocated, and the majority of these had occurred within a year of the first injury. Interestingly, they could find no difference between age and gender of the patients. Why is there a higher redislocation rate in adolescents? We're not entirely sure, but it's probably multifactorial. One factor is due to ligamentous laxity and immaturity of the structures that additionally help to stabilise the shoulder. The other is the high level of activity that all young people undertake. And the third is that there is actually a differing pathology. Navisa in 1993 described the anterior labroligamentous periosteal sleeve avulsion. In a normal Bankart lesion, there's a small avulsion of the bone at the insertion of the anterior inferior glenohumeral ligament into the base of the glenoid. This tends not to displace, and so a small bumper is often retained. However, they found in adolescents what they described as an Alza lesion. So this was really a displaced lesion, a little bit like a Saltaris 2 fracture, where the periosteum is stripped medially, and so that the small bony fragment actually ends up being displaced medially, so there's a loss of the bumper. They speculated that this loss of the bumper may lead to an increased incidence of redislocation. The standard treatment for a recurrent dislocator with minimal bone loss is a soft tissue Bankart repair, and we'd normally quote a success rate of 90 to 95%. So how do adolescents do with regards to surgery? Looking back at the study earlier, of the 102 patients that became recurrent dislocators, 60 had subsequently underwent surgery. This was 45% of the cohort, or nearly 60% of the recurrent dislocators. They all underwent a standard soft tissue stabilisation, but they had a redislocation rate of nearly 40%. 7 of them were revised, but there was no description in the study of what procedure they underwent. A study from Harvard in 2008 looked at 93 patients who'd undergone a standard soft tissue stabilisation for recurrent instability. 67 of the patients had a Bankart tear at surgery, whilst 26 were found to have an Alza lesion. They all underwent the standard arthroscopic stabilisation using 3 to 4 panlock anchors and were followed up for 47 months. At follow-up there were 10 redislocations. However, 5 of these were the Bankart group, which represents 7.4% failure rate, but 5 were from the Alza group, which represents a 20% failure rate. The other factor might be level of activity. In a study from Lem Funk's group in 2018, they looked at 67 patients, all under the age of 18, who underwent an anterior stabilisation for recurrent instability. 62 of them played rugby. They all had the same arthroscopic stabilisation using either pushlock or osteoraptor anchors, and an average follow-up of 33 months. They had a 51% redislocation rate. So what is the outcome with regards to revision stabilisation for this group of patients? Most of them have really got no bone loss, so in theory a repeat soft tissue procedure may work. A study from 2018 looked at 90 cases that had undergone a primary arthroscopic stabilisation of patients under the age of 18. There were 15 redislocations in this group. They all underwent revision surgery. 7 had an arthroscopic and 8 had an open Bankart repair, and at an average follow-up of 5.5 years, 33% had redislocated. They could find no obvious risk factors for failure. So this apparent high failure rate of a standard Bankart repair for an adolescent brings us towards the Instability Severity Index described by Pascal Belot's team. This system recommends that if a patient has a score of 6 or more, a soft tissue procedure on its own is unlikely to stabilise the shoulder, and perhaps a bone block procedure is indicated. Using their scoring system, any patient under the age of 20 who's involved in competitive contact sport automatically scores 5 before they've even started. Currently there are 2 bone block procedures that are in popular use. That is the Inhibin procedure, which is a standard bone block procedure, or the Coracoid Transfer. The usual indication for the use of a bone block procedure is for anterior glenoid bone loss rather than for straightforward soft tissue instability. The Inhibin procedure involves screwing a bone block onto the defect at the front of the glenoid. This will effectively increase the glenoid arc, stabilising the shoulder. A coracoid transfer involves fixing the tip of the coracoid onto the anterior glenoid defect, which again extends the glenoid arc, but this has the additional benefit of repositioning the conjoined tendon so that when the arm comes up into abduction and external rotation, it actually helps to stabilise the shoulder. This is sometimes described as the dynamic sling effect. So this procedure in theory is more suited to soft tissue instability than bone loss on its own. However, whilst bone block procedures have a good track record with regards to stabilising the shoulder, they carry a significantly higher risk and morbidity than a soft tissue procedure. There are a number of well-known complications. The anatomy around the front of the shoulder is distorted. It compromises subscapularis. There can be issues with bone graft donor site morbidity, and the patient is left with metalwork inside the glenoid. This is something that we should perhaps take into consideration when operating on an adolescent. To illustrate this point, this is a case that I've been involved in. In April 2014, a 14-year-old boy who was already 6 feet tall but playing academy rugby sustained his first traumatic anterior dislocation whilst playing rugby. He was seen at the local accident department where he was diagnosed as having an anterior dislocation which was reduced. This was then discussed in the fracture clinic and it was decided to treat him non-operatively with physiotherapy and rehabilitation. However, in August 2014, at the beginning of the next rugby season, during his first contact session, he sustained his second anterior dislocation. Following this, he underwent an anterior stabilisation using 3 biocomposite anchors. He rehabilitated his shoulder, but unfortunately a year later, when he returned to rugby during his first contact session, he sustained a further anterior dislocation. This is the MRI scan that was taken at the time, which can see that the anterior inferior tissues are very distorted and the 3 biocomposite anchors in place. He went back to see his surgeon and after discussion underwent an open latte procedure in February 2016 using 2 standard screws. We can see the X on the X-ray here. There's a satisfactory position. Little holes that we can see represent the voids from his biocomposite anchors, and also on the AP we can see his Hill-Sachs lesion. I first met this patient later that year. In August 2016 he returned to training and during the first session he had a fall. He didn't truly dislocate his shoulder, but following this felt that his shoulder was unstable on a day-to-day basis. We can see on the x-rays taken in our clinic that unfortunately his coracoid graft has failed to heal and he's broken the screws. This coronal CT scan taken at the time shows one of the issues. There are 2 metal broken screws in his glenoid and a number of voids from his previous biocomposite anchors. I had a long discussion with the patient and the options are to either try to revise his Latarjet or to undertake a bone block procedure. The concerns were with the glenoid bone stock. My experience in trying to revise a Latarjet is that the actual coracoid has often disappeared and it's not possible to do this, so we decided to undertake a bone block procedure. In February 2017 we undertook a revision Inhibin procedure using suture button fixation and an autograft. Prior to his operation we'd had a long discussion and explained that this was really a salvage procedure and that really he should not return to contact sport after that. He did exactly what he was told and began to start rowing. Interestingly, he's had no issues with his shoulder since then. He dislocated his shoulder when he was skiing, effectively at the age of 19. We undertook a standard Bankart repair in January 2018 and this is currently stable. So in summary, following a first-time traumatic anterior dislocation in an adolescent, there's a very high chance of this redislocating, over 75%. This may be due to the presence of an Alpsa lesion and may well be increased due to increased level of activity. Surgery for recurrent instability in the form of a soft tissue Bankart repair has a higher failure rate than normal of being between 20 to 30%. This may be due to the presence of an Alpsa lesion. In patients wishing to return to contact sports, this failure rate can rise to over 50%. Surgery for recurrent or failed instability in the form of a bone block procedure does have a better outcome, but does carry significant morbidity. In conclusion, the management of a first-time traumatic anterior dislocation in an adolescent does carry additional challenges for the health professional. It's important to have a robust and honest discussion with regards to the natural history of this injury and the outcome of all treatment options. Physicians should remember that they have a duty of care to the patient more so than to the parents or any team physicians. Ultimately, it's very important to try and manage expectations. If you'd like to see more videos on shoulder instability and other shoulder conditions, you may want to visit my YouTube channel Cambridge Shoulder or my website www.cambridgeshoulder.co.uk.